Welcome to Navigating Within from the Hospital Improvement and Innovation Network team here at the Iowa Healthcare Collaborative. My name is Dino Merhodzik, and I'm the host of Navigating Within. I'd like to introduce Mary Nelle Trefz. As a health policy associate, Mary Nelle performs research on various health policy issues to help inform legislation and develop evidence-based policies that protect and promote the health and well-being of children. Mary Nelle received her Bachelor's of Science in Health Policy and Management from Providence College in Providence, Rhode Island, and completed her Master's of Public Health in Community and Behavioral Health at the University of Iowa. I also have with me Lisa Cushatt. She serves as the program manager for Central Iowa ACEs 360 Coalition. ACEs 360 seeks to improve the health and well-being of all by empowering communities, organizations, and people to take informed actions to prevent and mitigate the lifelong effects of childhood adversity. Lisa is also an adjunct instructor in the human services field and previously served as the executive director for United Ways of Iowa. She has her master's in social work with an emphasis in policy, planning, and administration from the University of Missouri-Columbia, and her bachelor's in sociology from Truman State University. Welcome, guys. Thanks for being here. We're just going to go right into it. In our first session, we talked about the basics of trauma-informed care, but I'd like to see what your perspective is of trauma-informed care and kind of what you guys think about it and how you got into this.
So there's really four main areas for trauma-informed care. Most people call these the 4Rs. So realizing the widespread impact of trauma, how it impacts individuals, families, as well as our communities. The second R is recognize. What are the signs and symptoms of trauma? And that's really important not only from a practical application, but also from a system perspective. Do we have the policies and procedures set up that we are identifying where trauma has occurred? The third R is respond. So how do we apply that trauma-informed response and approach to policies, our programs, and our systems? And the final but absolutely important R is resisting re-traumatization. Unfortunately, our organizations, our systems, and our policies often re-traumatize individuals, and that can occur in every setting, including the healthcare setting. And so we really need to have a focus to ensure that we're not causing that re-traumatization. Those are some of the core philosophical and practical shifts for TIC. From my perspective, looking at the field, when I was in direct practice and working with individuals and young people, I really felt that we had to get at the root of what was either environmentally or personally causing them issues. Beyond that, then I really started to see that our systems and our policies weren't set up for folks who have been through trauma to be successful. And that's really where my interest from this work came in.
And Lisa did a great job of walking through those 4Rs. This is Mary Nelle, and I think the two things that really emerge for me when I think about the principles of trauma-informed care is, first of all, just realizing how universal trauma is. All of us experience adversity in some shape or other throughout our life. That adversity can look different and can be different in scale and significance, but I think it's an important universality to realize that we all have faced adversity and we bring that like baggage with us when we show up for work or school. And so just having that recognition that someone's behavior or how they might be responding to a particular situation might really be a reflection of what they are bringing with them to the day, some trauma that they may have experienced. And I think that's also leads me to my second point, which is something you often hear a phrase when you talk about trauma-informed care, but I think it's used often because it's a great way to really understand what we mean. And instead of asking, what's wrong with you? So when a child acts out in class, what happened to you? Maybe their parents were fighting last night and they weren't able to sleep and they were worried when the police came. So having that recognition and that sensitivity to what people are bringing to the table with them when they show up day in and day out, I think is really important.
Thank you very much. I think when I first started learning about trauma-informed care, it was weird to me because it always was something that you would think about, when you were thinking what people would experience and stuff like that. But until you actually kind of read into it and and you are given some of the statistics based on ACEs and stuff like that, how much trauma actually influences us and how it affects not only us physically, but our brain chemistry. I think trauma-informed care is something that definitely should be brought up in terms of when we're talking about caring for a patient or a family member or anyone that has experienced trauma in their life. So how has awareness of trauma-informed care grown across Iowa and across the nation?
So trauma-informed care, or TIC awareness, has really amazing foundations here in Iowa for almost a decade. Leaders such as the Trauma-Informed Care Stakeholders Group, based out of the Central Iowa region, the Eastern Iowa, Western Illinois Trauma Consortium, out of the eastern part of the state, have really moved the work forward. And groups like those are not only experts in Iowa, but they're also sought out as national experts. You frequently hear of national conferences that bring in some of the leaders from our state. I think that more specifically how trauma and trauma-informed care, as well as versus childhood experiences work, has grown in the last 3 to 5 years is just recognition. I think a real key to this movement is that philosophical shift and that perspective shift, and in looking at individuals and families and communities not as having a deficit in and of themselves, but looking at how their experiences have shaped them. And I think when you have that shift and start to build on their protective factors and their resiliency, both in healthcare settings as well as with partnerships external to the healthcare settings, that we've really started to see success. So it's that recognition, it's the continual naming of trauma and adversity that I think the more we talk about it, the more we're able to see shifts in our state and nationally.
And when we talk about trauma, I might experience trauma differently than someone else, which was something that was difficult for me to kind of grasp. But then once you read more about it, it makes sense that we experience trauma different. So what do you actually classify as a trauma? Is it case by case? Is there a standard practice that we should follow?
That's a great question, Dino. And there are some broad categories of trauma that we recognize across the board, but you bring up a good point that in some sense, trauma can be somewhat subjective because you and I may experience the same adverse event, but it might affect us differently. And one of the really important things to consider is the buffering effect having a positive adult in, for example, if you experience adversity in childhood, the presence of a positive, supportive, caring adult in your life can really buffer and mitigate some of the effects of that trauma, and from a physiological perspective can help your body regulate back to normal. So some of that stress response of those elevated cortisol levels, the increased blood pressure and heart rate, that can be reduced by having someone that in that child's life or young adult's life that they can turn to and rely on. So, maybe both of us experienced the same event, but one of us had that positive presence of a caring, supportive adult that would affect us differently. So that's a little bit why it can be somewhat subjective, but there are some broad categories of trauma that we can think of, adverse events that negatively affect an individual's physical, emotional, mental health and well-being, various forms of abuse, physical, emotional, sexual, neglect can be another form of trauma, as well as just general household dysfunction. So maybe experiencing domestic violence in the household, or thinking more broadly at the community level, community violence, experiencing poverty, discrimination. Those are all things that can be perceived as trauma in an adult or child's life.
When we try and tie trauma-informed care back to healthcare, healthcare in general, what I've realized from trauma-informed care is that it branches out into several different things, and it affects a multitude of different things, like you said, poverty and malnutrition and stuff like that. But tying it all back to healthcare, and we have a really big push right now in healthcare to improve the quality of care. How can trauma-informed care help us better the quality of care that we give to our patients?
So I think in looking at the quality of healthcare, there's a few things we can really look at, and where I feel that there are some great practices already going on in the state. And I think we have to be realistic and honest in realizing that there's certainly challenges with from a time perspective and from a resource perspective that clinics and healthcare systems can do. But I'll share with you a few of the things that we have really seen that can impact the quality of care. The first is education. While the science of stress is something that most providers learn in their medical training, really taking a longer, deeper dive into what that long-term impact of childhood adversity, trauma in childhood and adulthood does to the body. A couple ways that we've seen this done in our state is there's one specific clinic that in all of their staff meetings, for all staff, not just their medical providers, but their billing staff, their office staff, as well as every level of medical provider, they do a short component on trauma and a related topic every single staff meeting. That may only be 10 minutes, but that is a recurring learning that's given to the staff, embedding it in CMEs and medical conferences or trainings, having that be a requirement for anyone who works in your clinic or your system to have yearly training around ACEs or around toxic stress or trauma-informed care. So that education piece is really critical. The next piece is linked to community resources, having a strong resource and referral system. We know that it's not possible for every clinic to have a case manager or social worker on staff. But we do know those professionals and various programs are available around the state. So setting up a partnership where you have a method for resource and referral that is empowering to providers to know who they can actually refer to. It is helpful where there's a feedback loop that comes back to providers. So if there is, for example, a mental health concern, to know that someone has connected with a mental health provider, and they're not going to know what the mental health provider did, but know that person is getting treatment. So that resource and referral is really important. The third thing that we see is around screening and assessment. Most providers already do some sort of screening tool that identifies some sort of stressor in individual's life, but really taking a laser focus and lifting that up in how they are doing. So having in their screening forms that they already do, making sure there's questions on stressors. Do you feel safe at home? Do you have access to food? Having that be standard for every patient who comes in the door will help identify by issues. And then lastly, looking at the environment. So is confidentiality present when someone walks up to the office desk? Are all of the office and billing staff aware of the critical role that they play in a positive quality experience? So those are some of the areas we've really looked at. And I think when you knit pieces together that work for a given clinic in their given community, that can really improve quality of care. It affects things like provider retention. It affects things like provider satisfaction, staff satisfaction, and all of that then will translate into better care for patients, and also allows for a more open relationship between the provider and the patient.
I think building off of Lisa's comments, we know, as I mentioned earlier, trauma is fairly universal. We know that at least 56% of adults in Iowa have experienced at least one form of adversity during their childhood. So we can infer that those folks who are accessing our healthcare system, there's a good chance that they may have experienced trauma themselves. And that can impact everything from their physical health to how they adhere to a medication management protocol, or how they absorb the information their provider tells them about instructions about their care plan. But it also impacts the providers, the billing department, the front staff, which I think was a great point that Lisa met. So through those interactions with patients, if one of the providers or administrative staff have experienced their own trauma, it might be triggered by their interactions with that patient, which could kind of go two ways. It might give that provider or that staff member a greater understanding and be able to relate with that patient, or since it's a triggering event, it might be harder for them to interact with that patient. So I think just looking at the interpersonal relationships between providers and patients is important. But I also think something that Lisa mentioned earlier about getting at the root cause is another way that trauma-informed care can improve the quality of care that our healthcare delivery system provides. Because I think that education and recognition of the psychosomatic process, of those emotional experiences, the process of experiencing adversity or trauma can manifest as physical healthcare symptoms. And I think a great example is we look at ADHD. So a lot of times the symptoms that may present and be recognized by a healthcare provider as ADHD, that's very similar to how experiencing trauma may manifest itself, very similar symptoms. So if you don't have that trauma-informed knowledge base, the healthcare provider might misdiagnose that individual as having ADHD and prescribe them with an appropriate medication. But it's actually just the manifestation of how trauma is presenting itself. So that ADHD medication is probably not going to address the trauma that that individual has experienced or is currently experiencing. So it's not getting at the root cause. And I'm sure there's various HEDIS measures and other quality measures that healthcare providers are being monitored on and held accountable that relate to things like compliance with medication protocol. That patient might continue to take the ADHD medication, but it's really not improving their situation. So that's another example of how being trauma-informed can actually really help improve the quality of care that's delivered.
Yeah, there are a ton of barriers, and one that I can think of personally would be cultural. My family's from Bosnia, and I can just see the cultural differences, and especially kind of being hesitant to answering some of those questions that a clinician might ask you. So I can see that there could be some barriers, but I think ensuring that providers stay at their clinics and at the turnover rate and stuff like that, keeping it small, and that way the patient and the provider can build that relationship over time and get more comfortable with each other, and that's when you really start to find the root cause and not just determine that ADHD will give you this medication, and kind of taking that deeper dive into stuff. So I think that's really important. When I look at some of these statistics in front of me, and when we're comparing individuals that have 4 or more ACEs, you are 2 times more likely to have diabetes, 1.5 times more likely to smoke cigarettes, 5 times more likely to have clinical depression. When we're talking about the physiology in the brain, what is the argument against, how about you just not smoke cigarettes? Or how about you don't eat that burger all the time? Or how about you make better choices? It's all down to the choice of the person. How do you counter that with talking about brain chemistry and how trauma affects our physiology?
Those were great examples you gave. One of the important things when we think about the impact of trauma on brain chemistry to remember is that genes provide our basic blueprint, but it's our experiences that shape what the structure and the architecture of our brain. There's a variety of ways that trauma can impact the brain. If we have frequent positive experiences, especially early in childhood, that strengthens our brain and our long-term relationships, our ability to have good attachment. When our frequent experiences are negative, they reinforce how we respond to stressful events, potentially throughout our life. The other key thing to remember when we're looking at that brain architecture and the long-term impact is also to look at stress. And we all respond to stress differently. All of us probably know physically what our body does when we're stressed out. For some of us, that means our heart races. For some of us, we get a knot in our neck. Some of us, we eat a lot. Some don't eat anything. So how stress impacts our body, we typically know how it physically impacts us. One of the challenges is if someone is going through that frequent or prolonged stress, their stress response system never shuts down. They have a frequent flood of stress hormones, particularly in childhood, but certainly throughout life. If you have that frequent flood of stress hormones, that can impact your brain development, and it can actually impact how your brain responds and regulates. So regulation is a key thing we talk about for some of the examples you mentioned. Regulation of emotions, regulation of stressful situations. How do we manage that? That is something that we all need to do. Kids, adults, everyone. In childhood, if we do not learn how to properly regulate or properly manage our emotions, we may see it come up in the classroom. Like Mary Nelle mentioned, we may see examples of where folks think it's a behavior issue, but it's much more due to trauma that has occurred in life. When we do not regulate, especially as we get to adulthood, when we cannot manage our stress, we look for other things to help us manage that stress. And oftentimes it is not healthy ways. So the physical process of smoking can be very relaxing for folks. People who say, when I get home from work tonight, I need to have a drink or two. That's to relax. When we look at those who use illegal substances, it may be mirroring or trying to stifle emotions or stress, oftentimes due to a mental health issue. And so these are coping mechanisms for individuals. And if we do not help them cope in a different or positive way, or help them regulate in a different or more positive way, then we're not necessarily going to see a change in the use of things that cause some long-term health impact and a variety of consequences for individuals. I will note, though, while we see some of these behaviors occurs, it's also important to remember that you may have a seemingly healthy adult that also is showing signs of heart disease, that has no maybe family history or behavioral behavior that has maybe caused or that you would consider a risk factor. Even when you control for all the risk factors, for those that have been through a significant amount of trauma, you still see an increased risk for a variety of health issues. So I think it's kind of a two-pronged approach. One, we want to help people cope and regulate in more positive ways and manage their stress in more positive ways, get them the mental health support that they need, but also making sure we know when trauma has occurred, because if you don't look at that, then there may be a risk factor that is hidden that you might want to note as someone, I don't really understand why they have early signs of heart disease or why they have COPD. It doesn't make sense from their chart. Well, do we know really the full history of that individual?
What I talked about in my my first session of trauma-informed care was this analogy of a bear in a forest. I don't know if you guys have heard it, probably, but that when you see a bear in the forest, your body prepares for either two things. You're either going to fight that bear or you're going to run away from that bear. So, your blood vessels dilate, your blood starts running, and your cortisol levels increase and all that. And the idea of what if that bear comes home every night with you. So I think that was one of the analogies that really struck me when I was looking into trauma-informed care and just thinking about, thankfully in my life, I've never had that bear come home at night, so I can't imagine somebody that does. So I don't know if you guys have anything else you want to cover during this. I'm kind of going to leave it open for any closing comments or anything like that. We went over a lot of stuff today, and I thank you both for being here and for taking the time. This is a great principle, something that we should definitely be talking about even more than we are now. So
Yeah, thanks for the
Thank you.
opportunity.
Thanks a lot.